Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to GP and researcher Dr Rebecca Payne about what general practice can learn from the research she's been involved with on remote patient care. In this conversation, Rebecca talks about her research into patient safety in remote consultations, what GPs can do to ensure remote consultations are safe, and lessons for practices about the systems that they need to have in place. She also talks about the wider implications of this research, including what it means for training and education. And we also discuss her research into how the shift to remote care has impacted on quality in primary care, what this could mean for the future of general practice, and what she hopes policymakers will take from those findings. Before we start, just a quick message to say that MIMS Learning Live Digital is taking place online across 4 evenings from the 10th to the 13th of March. If you need some help keeping up to date with clinical practice, our colleagues from our sister site MIMS Learning can help with this series of evening webinars. You'll have the chance to earn up to 6 CPD hours from the comfort of your own home or practice, with presentations from expert speakers who are passionate about their areas of expertise. For more information and to register for your free place today, visit mimslearninglive.com/digital. I'm delighted to be joined on the podcast now by Dr Rebecca Payne, who's a GP and a researcher at the Nuffield Department of Primary Care Health Sciences at the University of Oxford. Alongside her research work, Rebecca has worked in out-of-hours GP care since 2008, and she currently works as a rotational island doctor in Scotland for NHS Orkney. Rebecca's research interests are in the remote delivery of primary care, and she was part of the team that published a landmark paper last year in the BMJ looking at patient safety in remote consultations in general practice, which she's here to talk about today. Thank you for coming on the podcast, Rebecca.
Thank you.
Before we get into the paper that we're going to talk about, how is it that you actually got involved in research? What led you to this career path?
It's something I always wanted to do, but when my kids were younger and I was younger, there were very few options in my locality to do it part-time because the funding for these jobs came through having to work in a local practice. And so that fitted into one full-time job, which I just didn't have capacity for with 2 young children, one of whom was disabled. And so I went off and I did other things. I was a clinical lead for an out-of-hours organisation, a primary care clinical director in South Wales, went off to work for CQC in their inspection programme for urgent primary care. And eventually I saw advertised on Twitter a PhD looking at remote primary care and thought, this is really what I want to do. Is the time right for me to come back to research? And I contacted the team who said, well, there's a better way in than applying for this really competitive programme. Do an in-practice fellowship. That will give you the training you need and the research basis to then apply for a PhD. So that's what I did. And here I am today.
You mentioned remote consultations there, and your research into safety and remote consultations looks at why patient safety incidents occur and how to prevent them. But why did you become interested in that particular area as something to look at? And how do you get a study like this even off the ground? I
was interested because it's something I was very aware of from my work as an out-of-hours GP, as an out-of-hours clinical lead, investigating patient safety issues, working for CQC, looking at where things were going wrong, not just in individual cases, but within processes organisationally. So I was really lucky that Oxford were running the Remote by Default 2 study just at the time I joined the team. And so having had that background linked to patient safety work, it was the perfect area of the Remote by Default 2 study for me to get involved with. So I was really very fortunate with that timing coinciding with my existing area of expertise from out with the academic world.
So the study we were going to talk about was published in the BMJ last year. What exactly did you look at as part of this, and how did you find the sort of patient safety incidents that you analysed as part of the research?
So the study was actually BMJ Quality and Safety, although just last week it's been summarised as an NIHR alert in the BMJ. We started off by looking at the practices. So we followed 12 practices as a team for 2 years and incredibly didn't find any safety incidents related to remote consulting. And that was really different to all the media noise, things we were hearing from arm's length bodies. And so it was apparent there was a mismatch between the two. So we did 2 things. We looked at what were the practices doing that we were studying to stop things going wrong, but also looked for cases where things had gone wrong. So I was seconded off to NHS Resolution to see their closed case files where things had gone wrong in relation to remote consultation. We brought that information together with information from NHS England, 111 Wales, and eventually found 95 case reports where things had gone wrong and studied those in detail to really get to the bottom of what had gone wrong and then group that into themes. But these were rare. These were really rare. We looked so hard, we only found 95.
Yeah, that's what I was going to say, because when that study was published, we wrote about it on GP Online, and that's what we said. But the national papers also wrote about it, and they focused more on the things that had gone wrong. But the general finding was that remote consultations are really generally safe. Why is that, do you think? Why don't things go wrong more often?
So it's because of the stuff everybody is doing proactively to make it safe. So, for example, in practices, there's often that culture, well, if you're worried, just see them. Staff err us on the side of the caution, just bring the kid in. The support that practices have within the teams means that very often if somebody is worried, there is somebody they can speak to escalate care. So if a receptionist, say, has spoken to Mrs. Jones and Mrs. Jones just doesn't sound right, they talk to the GP. And the GP will often put them at the top of the triage list and call them straight back. People use their triage list flexibly. So they look up and down and think, oh, they're a bit sick, call them first. Oh, that one's okay, it's just a medication request, put them to the end of the day. And GP practices know who their vulnerable patients are very often. And also staff are really creative. They break the rules and create new ways of doing things and then adopt those new processes to create safer care. I mean, there are still some more things that can be done, but there are a few examples of the ways practices are proactively keeping patients safe.
Yeah, but where there were those safety incidents that you mentioned, were there any common traits that you found in terms of why those incidents had happened?
Yes, there were. And they really coalesced around issues to do with the patient, issues to do with the clinician providing the care, and then the setting and the processes within which that care was being delivered. So patient factors that made remote care risky were people who are already very sick. Yeah, if you've got existing complex disease and you get something else on top, it's really hard to work out what's going on and to safely treat those patients remotely. Similarly, where communication is impaired, that might be because somebody is delirious, that might be because they speak a different language to the clinician, it might be due to a learning disability. It could happen for all sorts of reasons, but if you can't communicate effectively with that person, it's more risky to provide care remotely. We saw some really sad instances where people have maybe had 5 telephone calls and been diagnosed wrong at the first one. They didn't get better, but they weren't brought in. And some medical conditions are just high risk to manage remotely. Things like chest pain, breathing difficulties. If the entirety of somebody's palliative care is managed remotely rather than phone calls in between face-to-face encounters, new onset psychosis, breast lumps, actually probably all the things that many colleagues would already be very concerned about managing remotely. And then in relation to the staff, something that was really risky was relying on a remotely made diagnosis. So where a wrong diagnosis was coded because it was a remote consult, they didn't have all the information, even when somebody was seen face to face, people then sometimes just assumed that first diagnosis was right and built sort of error upon error. It's harder to recognise clinical findings when you're not in front of the patient. It's harder to recognise just how urgent a case is. Communication is more challenging. And then the environment in which people are delivering care can really mess with your head when you're remote consulting. So I work in an area where we often get letters saying, the hospital's really, really under pressure. And the hospital's under pressure. Maybe you don't have as many in-person appointments as you'd like. And so that messes with your head and can sometimes lead you to over or under prescribe, over or under investigate, or just not do quite the right thing because of those wider system pressures. And then finally, actually what happens within the practice is really vital. We have, established processes over many years for patients that are there in front of us. So if I get distracted and forget to call a patient into the consulting room, they're still sitting there very cross at the end of the morning. They're physical reminder that Rebecca has stuffed up. But if that patient is on the end of the phone and I've forgotten to call them back, they're just lost in the ether, wondering if the doctor's going to phone, should they call the surgery back, what to do. And so distractions are really dangerous for remote care, because if I'm distracted at that moment, don't call the patient back, come out of their notes into somebody else's, forget all about them, there's no visible reminder. Other processes, if the way you order your blood test is I tick a box, somebody takes it to reception, the reception looks at the box and pop it onto the electronic system. How do you replicate that when there's no physical patient there to take it to reception? All of these things need adapting for the remote world. Continuity is so important. It's so much easier to provide remote care to people you already know. And then continuity of disease episode, that poor patient who'd had 5 phone calls, all following the wrong diagnosis. They were all with different people. If it had been with the same person, it's quite likely somebody would have realised. And then training needs are different. And we've got another paper looking at the training needs for the provision of remote care. So they're just a few things, quite a few things.
One of the great things about your paper, actually, is it's a really good example of research that can make a real difference in day-to-day practice, potentially quite quickly as well. So it must have been quite a rewarding piece of work to be involved in, because practices have been using this study as a way to work out how they can improve things about how they do remote consultations. How would you suggest practices use the findings?
So I would suggest they look at the paper and look at Table 2. And Table 2 has got some really practical suggestions about what can be done. And at all these different levels I've talked about, because there are things patients can do to make their own care safer as well. And things like preparing what you're going to say in the remote consultation, asking for written information afterwards, a text with an information leaflet, that sort of thing. So I was just looking at that table, thinking about what you need to do for every step of the process. What do your staff need? What do your processes need to look like? What can you communicate to your patients? And then having a look at, if you just Google Remote by Default 2 study, you can get to our project website. And we've co-designed some materials for patients and for staff. And the patient ones can be shared on a practice website, Facebook page, to really get that information out there where it can make a difference.
What are some of those resources that you've made for patients and staff then?
Yeah, so there's some leaflets that have been produced with graphic designers. They're bilingual, English and Welsh, to really get over how you can take steps to make your own care safer. For staff, we've got summaries of each major theme of the study, and we've got some competency lists of the training that is required for all team members. Because, of course, it's not just about the GPs and the clinical staff.
Yeah.
Actually, the receptionists are so vital here. And we've just got funding to develop a practice pack, a sort of choose your own adventure style thing you can do in a training afternoon, putting cases through your own systems and working as a team to see how you would manage problems and where the bear traps might lie. That one isn't finished yet, but will be coming soon.
Have any practices told you they've made changes as a result of your research, and what sort of things have they said they've done?
Yeah, they have, and that is so wonderful. Things like looking at who is doing the telephone consulting and making sure it's the most experienced members of staff, looking at how registrars deliver it, so not letting the most junior registrars do it, putting in place that training and support and then doing it. I've heard about practice processes being adapted, just that sort of thinking through everything. How does this work in the remote world? Because we had to make those changes so quickly at the start of the pandemic. A lot of the thinking has been done sort of afterwards, when in an ideal world where you don't have a pandemic, it would have been good to think that through before. And that's a really wonderful thing about this research. It makes a difference in the real world. It's stuff that was worth getting out of bed in the morning to do.
One implication, obviously, of this research is in teaching, and in teaching how to ensure remote consultations are safe during GP training. You have written about that. How do you think training and education, in particular GP training, might need to change to reflect that?
There's a couple of things. One is the training of our new GPs. And I think that's something that people have given a lot of thought to and is being addressed. But we've got an awful lot of people like me that have been in the workforce a long time. And the job I do now is different to that job I was trained to do quite some time ago now. And I think that's the area that we really need to focus on. And there's so much tick box mandatory training out there that, It's tempting to just whiz through it as quickly as you can and get that certificate. That's not what we're talking about here. Actually, we need to train with the people we work with in the environments where we work. And people like A&E teams and disaster relief teams, they know this and they do this. But in general practice, we need to look at how do our processes work and where are the gaps and what training does each member of the team need to deliver effective care. So that's one of the reasons I'm quite excited about this practice package, looking at using case stories with their systems, because I think that will really pull out both the individual and the system gaps. We have to do this together. We deliver care in teams. We need to train in teams.
So much of it is about the processes within a practice, isn't it? Because it's never just a GP and a patient. There's all the other bits that go on around it that have to happen properly as well. If you were trying to sum up all of this for GPs and practices, what's the key bit of advice you would give them when it comes to ensuring remote consultations are safe?
Yeah, it's so hard to choose. But I guess there's one from the patients, the staff and the setting. So for the setting, make sure your processes work in the remote world and adapt them so they do.
Yeah.
For the staff, I think it's a mantra I was told many years ago. Have you got enough information to answer the question here? Actually, going to have two for staff. Because if you don't have enough information to answer the question remotely, you need to see that patient in person. And the second one is treat a remote consultation diagnosis as provisional until it's been confirmed in person, because it's so easy to build error on error. And then I think in relation to the patients, it would be just think about, is the patient to whom you're offering remote care suitable for that modality? And there might be something intrinsic to them that makes it less suitable. It might be their acute disease. It might be the condition that they suffer from long term. My dad loves saying there's a tool for every job, and we need to use the remote consulting tool wisely because it's not suitable for every job and every person.
Are there any sort of groups of patients who remote consultations shouldn't really ever be considered? And do most practices have those sorts of systems in place to basically say, we don't see this group of people remotely?
I think it's hard to be hard and fast about this, but many practices know who their vulnerable patients are and those that are less suitable. So if there are communication challenges, if there are complex comorbidities, it may be less suitable, but then you may have the ability to add in video and get extra information. You may have somebody with complex comorbidities that is much more comfortable receiving their care from home and can articulate clearly and give you the information they need. They may have things like pulse oximeters and thermometers that make it easier. So I don't think there are hard and fast rules. I think actually it's a really contextual decision. So no easy answers here, I'm afraid.
You mentioned continuity. I suppose that also comes into play, doesn't it? Because if it's a patient that a GP has a long relationship with and sees very, very regularly, obviously having a phone conversation with them is very different from having a phone conversation with someone they only see very intermittently.
Absolutely. And it's like the palliative care issue. We saw some awful examples in the data set of people whose care had been managed wholly remotely. But there's loads of people who would maybe have 3 phone calls for a palliative care issue for every appointment in person and are really satisfied with their care because they have that continuity. The GP knows what's going on. They can assess the symptoms in the light of what they know about the home and the patient. And video is so useful. I know we don't do it very much anymore, but it does give some really useful additional information. It was massively used at the start of the pandemic, but as in-person appointments got easier, a lot of GPs felt it just wasn't worth the faff of setting up a connection. It's still got niche uses though. It's used a lot more in the out-of-hours sector. There's some practices, particularly in Scotland, that use it quite a lot. It's now been mandated in Denmark, so every Danish GP has to offer a patient a video call if that's how they'd like to have their care delivered. So it would be really interesting to see that learning from Northern Europe. But yeah, not used much in the UK, sadly.
You mentioned that you've got some other stuff coming out about this. Are you planning any other follow-up research or anything like that?
I'm really interested in the question as to what happens after the teleconsultation, because we deliver so much care by phone. 111, 70% of all calls out of hours are dealt with by phone. But that poses some real challenges about how you can get access to medication. We're seeing community pharmacies close, out of hours deliver more care by phone, so there's less spaces a patient can collect from. So I've got a very cool project with a medication machine that the clinician logs into and can issue from the out-of-hours formulary to a patient after a 111 call. So the first one has gone live in North Wales and we're just trialling it at the moment. But those really practical solutions to what happens next, that's a bit I don't think we've really thought through, particularly in that UK setting of closing pharmacies. So I want to see if there's solutions there. It's not enough just doing the call if the patient is left unable to get the medication they need at the end of it.
So what happens then?
So this machine sits in Dolgellau in the patient's community, in the car park, lots of CCTV, very secure. Everyone always asks about that. The out-of-hours team there have decided what medication they think is most important to go in the machine. So nothing sexy, it's just antibiotics, steroids, inhalers, that sort of thing. And the patient has their phone call as normal, and then the clinician logs into the machine. They link that medication to the patient, read out a PIN code to the patient and text it to them as well. They go to the machine, pop in the PIN code, and out comes the meds. First one in Europe. There are some similar machines in North America, and I'm very excited to have got a Churchill Fellowship to go and look at them in Alaska this summer. But no, this is a first for Europe. We've had to adapt the machine from existing hardware together with the manufacturers. So really exciting, innovative project.
So are you involved in that as a researcher, or is it something you're doing as a practicing GP?
No, I'm involved as a researcher. So we've got a really interesting design where the researcher is embedded within the project team. So all that knowledge I have from far too much out of hours over the years, I can bring to bear because I'm not just studying it as an outsider, I'm studying it as an insider. And there's a fantastic team, both in North Wales and in the supplier and the manufacturer, who have just worked so hard to get this up and running. And it's already making a difference for patients. So we'll just see how much of a difference in the study.
One of the things I want to talk to you about was another bit of research that you've been involved in, which was published in the British Journal of General Practice in January this year. That actually also came out of the Remote by Default project, didn't it? So this was looking at quality in general practice in 12 practices across the UK over a 28-month period starting in 2021. It was aiming to look at whether quality had been affected by that shift in how practices operate towards more remote consultations. How did you go about looking at that?
So that was the most depressing piece of work I have ever undertaken. We had all this research coming in from our researchers in residence. They had field notes, they had interviews, so lots and lots of really rich data from the practices. And we combined that with external sources, patient reviews, CQC and Inspectorate Wales reports on the practices, CQC's National State of Care report, and some other sort of high-level data. And that really helped build up a very rich understanding of how quality was affected. So we analysed that against a couple of, or three different quality domains. So there was the Institute of Medicine domains, which people will be really familiar with because they're very similar to CQC inspections. And then we used the STAR field, core values of general practice, which many GPs really feel is at the heart of what general practice should be. And then we used the new LADS ontology of primary care continuity, which looked at continuity in the modern world. I sat there in Orkney getting more and more depressed going through this really, really sad data, which demonstrated just where the challenges lie and how difficult it is under current circumstances to provide the level of care that we all aspire to.
It is a really extensive piece of research, and I think it's actually really important, and it's a really important thing that I think that policymakers and people should read because it really sets out the challenges. And it's not just about how general practice has changed, is it? It's also about general practice working within a system that has been subject to 12 years of austerity where everything is just really, really hard for the people working in the NHS and in social care. Can you summarise a bit about what the study found?
Yeah, so, firstly, the context, just as you've highlighted, the context in which we're delivering care is really tough. So that austerity you mentioned, the loss of resilience across the system, we see Meals on Wheels withdrawing that offering, that it's harder and harder to get home care. If you've got a palliative care patient, it's harder to get a home carer. Mrs. Bloggs might have taken Mrs. Jones next door to the surgery in the past, but, Mrs. Bloggs is 64 and maybe now is either working herself still into an older age or busy looking after grandchildren. So we've lost some of that societal resilience that kept vulnerable people in our communities supported. And that means official services are stepping into the gap, particularly general practice. We've seen that the whole system is under strain. So if somebody's waiting 2 years for a hip operation, every month or every few months, the GP is reauthorising their painkillers and supporting them and seeing them. So that broken system is creating much more work for practices. We've seen really complex patterns of illness, things that would have been treated in hospitals before. We manage now out in general practice, but without those hospital resources, the impact of COVID as well. We have a lot more disabled people in the UK now. And then the technology itself, in the past, if somebody wanted me to do something urgently in the middle of a consultation, they'd apologetically knock the door, bring me a cup of tea and ask me to do it. And I'd be so delighted to have a cup of tea. I was happy to do it. But now, ping, 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 another task on the task list. And those loss of in-person interactions, they really weaken the bonds between staff and make it more difficult to work together as a team. So it's really difficult context. And then it's really hard to balance the benefits of this digital world with the trade-offs. And there are benefits for some people. But actually, people who struggle to access the online system, who can't clearly explain their problems and what they want to get out of the consultation, they're being left behind. So access and triage is really difficult to provide care for the people who need it most. Long-term condition management is really hard to do effectively online for many conditions and many people. And we saw instances of a practice would send a link to a web form for a patient to complete. They didn't quite understand the questions, so wrong information entered their patient record. It was reviewed. Yes, they're absolutely fine, when they weren't. They just didn't understand the questions. So long-term condition management, it really needs to be tailored for the patient if we're going to provide it remotely. And some things like, say, diabetic foot care, really risky to do remotely. And then another thing was the human elements of care and compassion are reduced by over-protocolization, by an electronic message. You might say, complete a web form describing symptoms of a miscarriage and get a text saying, well, you need to go to the early pregnancy assessment unit for that. How impersonal is that? We can't fix everybody, but I was always taught we can always care and show that compassion. And actually, the way our systems are now set up limits that. That causes real stress for staff because people enter general practice to make a difference. And when they don't feel they're making that difference, that causes real angst among the workforce. And we've got another paper just out on techno stress and just that impact on staff of the ways in which care is currently provided.
One of the things that's actually worth mentioning here, and perhaps you can explain how this works, is the remote by default study. That works with having researchers kind of embedded in these practices. The research team, they really understand the practices that they're working in, and they get to know the staff and how they're set up. How does that help you in terms of pieces of research like this?
So that means we get really rich, deep insight. So anybody can behave themselves for a day when there's somebody shadowing. But after 2 years, that researcher is part of the wallpaper. You forget that they're there. And they do keep reminding them we don't want to do anything unethical and people not consenting. But they really become valued by the practices, part of the furniture, able to have conversations. So it gets that data that you can't get from interviewing a stranger or just observing for an afternoon. It's one of the great assets of ethnographic observation in research. A clinical trial would have never brought out the richness of the data that we've been able to get from those practices.
With that piece of research, this last one we were talking about, quality of care and stuff, was there anything in that was particularly surprising?
What I've found surprising across my involvement with Remote by Default too is actually technology and progress doesn't always give the benefits I assumed it would. So I'm quite a techie person. I have a robot vacuum cleaner, a robot lawnmower. I love gadgets and toys. I was one of the first to adopt video consulting. I love it. But actually, it was so depressing seeing the downside of that. So I had thought before that digital triage access systems would mean that by everybody who could putting stuff online, there'd be more capacity freed up for those people that couldn't. But actually, that's not what's happened. The capacity has been taken up by the people that can put it online, leaving little left for the most disadvantaged. Things like that. I guess I've done remote consulting for many, many years as an out-of-hours GP. I feel like I've had a good understanding of where it was used. But actually, certainly in the cases from the beginning of the pandemic, the way it had to be applied to everybody meant that some real challenges arose. So I'm disappointed in tech. It's not providing the salvation I hoped it would. The human elements of what we do are so important.
What do you think's the answer, though? Because there's no way NHS England in particular is going to back away from digital. And obviously there's this whole idea about we've got to have more tech, we've got more AI. You know, this whole idea from moving from analogue to digital, that's going to be a really important part of the 10-year plan. So what do you think the answer is then? How can general practice function effectively if we are still going to have like digital triage and online access to general practice?
We need to be clear about three things. What is the problem we're trying to solve by using technology?
Yeah.
Because I feel that we use it often without having that clear idea of what its niche is and where the value is. I think the second one is being really clear, and I think further research is needed to really tease out more where it is and isn't helpful. And of course, that needs to be contextualised for the patient and the setting. But if we know, for example, that it's generally unsafe to manage diabetes care fully remotely, we can stop doing it. We need that knowledge there. And I think as well, we need recognition that where we have technology, we need a plan B for those people for whom it is less appropriate. And there's some parts of society like trying to access a benefit system. I was helping a friend with this. There seemed to be no plan B. You had to fill in the wretched form. We shouldn't let general practice be like that. Health is so important. We have to have a way to provide it to the people that really struggle to get their heads around tech or don't have the tech or are already disadvantaged. So it's that sort of being strategic about all of this. I think that's sometimes been the bit that is lacking, particularly perhaps at the policy level. We need to get that balance, that nuance. Kind of doesn't make for politician speeches that, have those sound bites if you're getting that nuance, but nuance is what we need. And to me, and this may seem naive, but it seems reasonable to me that if a patient feels they need to see a GP, perhaps we just need to see them. And very often spending a bit of time with somebody can deal with the reason they've come in the first place and change that behaviour for the future as well. Because we also saw a lot of examples of patients hopping around the system, being pushed from pillar to post. So they might go to the pharmacy and the pharmacy say, oh no, we can't treat that, you need to see a GP. Them calling the GP, but it's later in the day because they've already been to the pharmacy, and the GP saying, well, we've got no appointments now, call 111. And they call 111 and they go to the out of hours GP, and the out of hours GP sees them and says, well, I can do this today, but you still need to see your GP. So it's interesting to think about how much efficiency or inefficiency have we actually introduced to the system. Do we just need to make enough capacity in general practice to do the job properly and save all these multiple touch points?
You've mentioned a couple of papers that you've got coming out. So are these all part of the remote by default study as well? What else are you looking at as part of that study?
Yeah, so we had 5 different themes. Most of the papers are now out. So there's a really helpful education paper that in the supplementary material has got the competency list for each member of the practice team. So that one is out and that's super helpful. There's one on technostress, and there's also a brilliant paper by Francesca Dakin on candidacy and access. Of all the papers I've read in the study, this one really made me think, what are we doing? She demonstrates how when patients struggle to effectively engage with either remote triage and access systems, so either online or telling their story, wrong information gets through to the record. And that's so scary, isn't it? Because I look at the notes and I assume the information is correct, but that is not always the case. So really, really important paper. There's one on media as well. And there's a load of spin-offs as well. So one on teaching patient safety, one on a tool for every job on video consultation in urgent care. There's a brilliant one, 3 strikes and you're in, with the rule that you shouldn't have multiple remote consultations for the same thing, by Trish Greenhouse and Rebecca Rosen. But yeah, they're linked from the Remote by Default 2 study page. Really helpful, practical stuff in there.
It sounds really good. That's brilliant, Rebecca. Thank you so much for coming on the podcast.
Thank you. I enjoyed it.
Well, that's it for this week. Thanks so much for listening, and thanks again to Rebecca. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news relating to general practice and access lots of other resources and information on our website at GPonline.com.